Today, we are taking on a subject that really underpins every single medical interaction, every hospital visit, and every policy debate you've ever heard.
It really does.
We are diving deep into the often overlooked, very complex world of health systems science.
It's the context in which medicine is actually practiced. When most people talk about healthcare, they focus on the clinical diagnosis, the disease itself, which is natural.
Of course.
But health system science, or HSS, is really the scaffolding that supports the entire structure. It's all about the operational realities.
Like how care gets paid for.
Exactly.
Wow.
How it's paid for, how safety is engineered into the system, how really tough ethical decisions are made, and how communication either succeeds or just fundamentally fails.
That's right. So our mission today is to cut through that complexity and deliver the foundational knowledge, the high-yield facts that you need to be instantly well-informed about the operational machinery of modern healthcare. We've synthesized a stack of sources that provide the absolute core facts of HSS, bridging everything from finance and communication with ethics and professional accountability.
And this material is incredibly broad. I mean, it bridges multiple disciplines you might not immediately connect to medicine.
Right.
We're talking about everything from the specific ways a primary care office gets reimbursed for a routine visit, all the way to the legally mandated structures for informed consent during a high-risk procedure.
And even down to the psychology of it all.
Right down to the psychological stages a patient moves through when they're deciding to change a behavior, like quitting smoking. So we're going to unpack these dense concepts, not just define them, but really focus on the patterns and the profound implications they have.
Implications for what exactly?
For the safety and the experience of the patient and for the conduct of the professional.
So what does this all mean for you, the learner? It means you get the critical, sometimes surprising facts about the processes that dictate healthcare delivery. We're basically providing you with the playbook for how the system works.
That's a good way to put it.
Okay, let's unpack this. We are starting where the system itself begins.
Where the money is.
Exactly. The movement of money and how that fundamentally defines the structure and the incentives of care.
Let's do it.
Patients use services, providers get reimbursed. It sounds simple on the surface, but how that payment happens really dictates the incentives across the entire health system, doesn't it?
Oh, absolutely. It influences everything, from how much time a clinician feels they can spend with you to whether prevention is financially prioritized over, high-cost procedures. This is maybe the single most important concept for understanding systemic behavior in medicine.
Okay.
Our sources identify 4 core models, though you could argue 5 in practice, that are used to structure these payments. And these methods directly impact whether a clinician is rewarded for volume or for successful outcomes.
Let's analyze these payment models then, starting with bundled payment. What is the mechanism there and what's the incentive?
Okay, so with bundled payment, an organization receives one set fixed amount for an entire episode of care or specific service.
So think of it like a package deal.
Exactly. It's a package deal. For example, if you need a knee replacement, the insurance company pays a single bundled rate.
And that covers everything. The surgery, the hospital stay.
Everything. The surgery, the stay, the immediate post-op physical therapy, and the follow-up visits, all within a fixed time frame.
So the goal is pretty clear.
The goal is crystal clear. It encourages collaboration and, critically, cost control across all the different providers and facilities that might be involved.
And if they're efficient, they profit.
Right. If the organization delivers that care more efficiently, they keep the difference. If they go over budget, well, they absorb that loss.
Okay, so the next model, capitation, seems to flip that incentive structure entirely.
It absolutely does. With capitation, clinicians or organizations get a set amount per patient per period, say monthly or annually. And this is regardless of whether that patient actually uses any services or not.
And that's the model for HMOs, typically.
That's right. It's the backbone of health maintenance organizations.
The implication there is profound, isn't it?
It is. I mean, think about it. The organization gets the same fixed revenue, whether the patient is sick and needs multiple expensive visits, or if the patient is perfectly healthy. So the focus immediately shifts to preventative health and wellness. The organization is financially rewarded for keeping the patient healthy and out of the clinic or hospital. It's really the only major model explicitly incentivized toward proactive health management.
So interesting. Now, let's get to the traditional model that, maybe unfairly, defines medical billing for a lot of people. Fee-for-service insurance.
Right. With pure fee-for-service, the patient or their insurer pays for each individual service performed, every test, every stitch, every 10 minutes of consult time.
And that creates a powerful, but potentially problematic incentives.
Yeah. Potentially perverse is the word sometimes used. The more services you provide, the more payment you receive. And while it ensures ready access to any potentially needed care, the inherent risk, as our sources point out, is the potential for overuse.
Over-testing, over-treatment.
Exactly, because the financial reward is tied directly to volume, not to necessity or outcome.
But the reality today is that pure fee-for-service is pretty rare, right? Most organizations are using a discounted fee-for-service model.
That's the most common model, you're right, particularly in the employment-based insurance landscape. Here, the insurer pays a discounted rate for each service, but that rate is pre-negotiated between the providers and the payers.
So it's an attempt to mitigate that overutilization risk.
It is. It tries to cap the payment per item, but it still keeps that itemized billing structure.
And finally, a model that sounds a lot like bundled payments, global payment.
It's conceptually very similar. Global payment is essentially the most comprehensive payment approach for a focused incident. It involves one single, fixed amount that covers all expenses for a single incident of care.
Even if it takes place over a long period.
Even then, the classic example is for a complex elective surgery. The payment might cover the procedure, all the necessary pre-op tests, and all the post-operative follow-up visits within a set recovery window.
So it provides simplicity and predictability.
Exactly. Total cost predictability for one specific event. It really streamlines the administrative complexity that can be such a burden on patients.
Understanding how the money flows is key. So now we move to the foundational government programs, Medicare and Medicaid. For our listener, why is it so vital to know the administrative and eligibility differences between these two?
It's vital because it directly dictates patient access, the scope of care they receive, and even the financial stability of the hospitals and clinics that serve them. They represent fundamentally different philosophies, and confusing them means you're misunderstanding who gets what type of care.
Okay, let's pull the key distinctions from our sources, specifically Table 2.51. We can start with the administering body. Who runs these programs?
Right. So Medicare is administered entirely at the federal level. It's a national program.
And Medicaid.
Medicaid is different. It's a cooperative program administered jointly by the federal and state governments.
Which means it can vary a lot from state to state.
Tremendously. Medicare standards are pretty uniform nationwide, but Medicaid coverage and who is eligible can look very different depending on where you live.
And what about the fundamental type of program? Is it insurance or assistance?
That's a critical distinction. Medicare is legally classified as an insurance program. It's something you earn, largely paid for through decades of payroll deductions.
Whereas Medicaid?
Medicaid is classified as an assistance program. It's designed specifically to aid those with financial need. And that distinction is key to how they're funded and how they're viewed in public policy.
Okay, now for the biggest difference impacting patients. Eligibility. Who qualifies for Medicare?
Eligibility for Medicare is primarily based on age. So patients 65 years and older.
But there are exceptions.
Yes, and they're critical exceptions. It also covers younger patients with specific long-term disabilities, and it covers patients of any age who require continuous long-term renal dialysis for kidney failure.
And Medicaid eligibility is completely different.
Completely different. Medicaid eligibility is based entirely on income level. It covers low-income patients of any age, children, adults, the elderly, who meet the financial criteria set up in their particular state.
Let's talk funding. How are these massive programs paid for?
Medicare is paid for through trust funds, specifically the FICA deductions that are taken from your wages over a lifetime of working.
And for Medicaid, since it's assistance.
For Medicaid, the vast majority of patients generally do not pay any part of their expenses. It's a mechanism of financial assistance funded through general taxes.
What about the out-of-pocket costs for the patient? Copays, deductibles?
For Medicare, there are generally small monthly premiums for certain non-hospital coverages, and deductibles apply before the coverage kicks in.
Though people can get supplementary insurance for that.
They can, yes. For Medicaid, it typically requires only a very small copayment in some specific cases. But for many services and for the most vulnerable people, there are often no copayments at all.
Now, let's drill down into the famous complexity of Medicare. It's divided into parts A, B, C, and D. What exactly does Part A cover?
Part A is often called hospital insurance. It covers the costs that come with an inpatient hospital admission.
So the room, meals?
Right. Semi-private rooms, meals, necessary services, but also limited skilled nursing facility care, home health care, and critically hospice services.
And Part B is more for the day-to-day interactions with the healthcare system.
That's right. Part B covers your basic medical bills. So clinician fees, outpatient services, preventive care, diagnostic testing like blood work or x-rays, and durable medical equipment. Basically, things that happen outside of a formal hospital admission.
Where do private insurance companies come into this?
That would be Part C, which is known as Medicare Advantage. This is basically an alternative way to get your Medicare benefits.
So you're still in Medicare, but a private company manages it.
Exactly. Approved private companies contract with Medicare to provide all the services of Parts A and B, and usually Part D, often bundled with extra benefits like vision or dental care.
And finally, the one that was a huge game changer for many older adults, Part D.
Part D is the prescription drug coverage. It's delivered through private plans approved by Medicare, and it helps pay for the cost of prescription medications. It's so critical because for a long time, Medicare had this huge gap with no comprehensive drug coverage.
So you have this very structured, multi-part coverage with Medicare. How does that contrast with Medicaid's scope?
Medicaid coverage is designed to be broad and comprehensive for low-income patients. It covers basic health care, prescription drugs, but also these critical, often life-changing services like long-term care.
Things Medicare doesn't really cover.
Right. Long-term care, medical equipment, prescription glasses, dental care services that Medicare either doesn't cover or covers only minimally. So, in short, Medicaid covers a much broader, and you could argue deeper, array of non-acute medical and supportive services.
That detailed breakdown is incredibly helpful. It gives us the financial and structural context. Let's shift gears a bit and transition to palliative care, a critical component of HSS that deals directly with quality of life and suffering within the system.
The core definition of palliative care is so important, and it's where a lot of misunderstanding happens. Palliative care is not just end-of-life care.
That's the key distinction.
It is. It's an approach dedicated to improving the quality of life for any patient experiencing a life-threatening illness and for their families, regardless of their prognosis or their current treatment status.
So the focus is on relieving suffering.
Relentlessly. Preventing and relieving suffering in all its forms, physical, psychological, social, and spiritual.
So just to be clear, a patient can be receiving aggressive, curative chemotherapy treatments and palliative care at the same time.
Absolutely. The palliative care team, which can include clinicians, nurses, social workers, chaplains, they can be involved from the moment of diagnosis of a serious illness. They work right alongside the curative team to manage symptoms like pain, nausea, anxiety, or depression.
Our sources lay out 5 distinct stages that outline the emotional and clinical arc of this care. Let's walk through them. Stage 1 is stable.
Okay. In the stable phase, the diagnosis is confirmed and a full treatment plan has been created. The medical focus here is on optimizing that plan, controlling any existing symptoms, and really enhancing the patient's quality of life as much as possible while they undergo their primary treatment.
Then you have stage 2, unstable.
This is where symptoms might worsen unexpectedly or new severe symptoms emerge. This requires an immediate modification of the treatment plan.
So the clinical focus shifts.
It shifts heavily toward intense management of these new symptoms and also providing really robust emotional and spiritual support as the patient has to adjust to this setback or decline.
Stage 3 is deteriorating.
This stage marks the gradual, sort of expected decline of overall health and body functions. It's less about unexpected crises and more about managing that steady decline.
And the focus here shifts again.
It intensifies on addressing the patient's mental and emotional distress and, crucially, providing ongoing support for their family and caregivers who are witnessing this decline firsthand.
Stage 4 is terminal. And this is where palliative care often becomes the only goal of care.
That's right. At the terminal stage, the patient may become bedridden, their appetite decreases significantly, and difficulty swallowing is really common. Medical interventions become overwhelmingly palliative-focused entirely on comfort.
And they might need to move to a dedicated facility.
Often, yes. A transition to a hospital or a dedicated hospice setting is needed for that focused care and more aggressive symptom management.
And finally, stage 5, which is bereavement. The patient has died, but the system's obligation to care continues for the family.
This is so vital. Bereavement care focuses entirely on supporting the patient's loved ones in the aftermath of that loss. This means emotional support and actively connecting the family with specific resources tailored to grief and loss.
Like a pastor or support groups.
Exactly. Connecting them to a pastor, priest, rabbi, or structured psychosocial support groups. The care doesn't end when the patient dies.
What's the key clinical distinction then that dictates when a patient moves from general palliative care to dedicated end-of-life care, meaning hospice?
The crucial clinical decision point is the prognosis. If the life-prolonging treatment is deemed no longer beneficial, or if the prognosis for the patient is determined to be 6 months or less, that's when the patient is referred specifically to hospice care.
And that 6-month window is important for insurance reasons too.
It is. That distinction is important because hospice care often involves specific insurance criteria, like Medicare Part A coverage, that are tied directly to that 6-month prognosis.
We've established the system's structure. Now we need to turn inward to the human interaction at the heart of it all.
Communication.
Effective communication. It's the lifeblood of healthcare. It's the most challenging, yet the most essential skill for getting a reliable history and building the trust you need for successful treatment. We're going to dive deep into the frameworks that turn a standard interaction into a patient-centered, evidence-based exchange.
The goal, as you said, is twofold. You have to make the patient comfortable, and you have to obtain a reliable history. And our sources break this down into specific, detailed steps that ensure respect and systematic information gathering.
Okay, so step 1, setting the stage. This is about creating a respectful environment from the very first moment.
Right. Setting the stage means using the patient's preferred name or pronouns and addressing them directly, not through a caregiver. You have to clearly introduce yourself, identify your specific role, and, importantly, ensure privacy.
And what if family is in the room?
If caregivers or family are present, you introduce them, and then you have to clarify with the patient, out of respect for their autonomy, if they want that person included in the discussion.
Step 2 is establishing the agenda of the interview. This sounds like it's about managing expectations and time.
It is. Transparency is key. You need to indicate the time you have for the discussion. You list the issues the patient wants to discuss, and then you let the patient prioritize those issues.
So the patient defines the agenda.
Patient defines the agenda. Then you summarize how the interview will proceed. It sets mutual expectations and gives the patient a sense of control over their own visit.
Okay, next we move into actually getting the information, starting with non-focused expression or reflection.
This is the broad starting point. You begin with those open-ended queries, tell me what brings you in today, and you use nonverbal cues like nodding, leaning forward, or even just silence to gather that broad initial information without leading them. You're just listening for their story.
And that leads naturally into focused expression or validation.
Right. Once you have the broad picture, you transition to getting more focused history. This requires explicitly focusing on the impact of the illness, the personal, psychosocial, and emotional effects. It's not just about the symptoms.
It's about how the illness fits into their life.
Exactly. Identifying the patient's beliefs, their attributions, and how this whole thing is affecting them.
A masterful interview relies on advanced skills beyond just basic questions. Let's detail these, starting with understanding revalidation.
This is a critical check for accuracy and collaboration. It just means summarizing what you've heard the patient say and then asking them what needs more input or correction.
So what I'm hearing is X. Is that right?
Precisely. It ensures you and the patient share a mutual understanding of the history before you move on to the exam or treatment plan.
Then there is facilitation.
Yeah.
How do clinicians encourage a patient to, open up?
Facilitation encourages them to speak freely, often through techniques that don't feel technical at all. This includes using judicious silence, nonverbal encouragement, or just repeating a key word or phrase the patient used to prompt them to elaborate.
So if a patient says, "I've been feeling tired," you just repeat, "Tired."
Exactly. Tired. And then you wait. It's incredibly effective.
Open-ended skills are another vital set of tools.
These are the explicit techniques that encourage the patient to elaborate without steering them too much. Things like silence, reflection mirroring back their sentiment, and clarifying statements like, "Can you tell me more about that pain?"
We've talked about the history of symptoms, but how do we effectively get into the emotional landscape of the illness with emotion-seeking skills?
These are direct, explicit attempts to ask how the condition is impacting the patient's feelings and their wider life.
So you ask something like, "How has this affected your family?"
Precisely. Or, what impact has this uncertainty had on your morale? You're moving past just the clinical details to identify the specific emotional weight of the problem.
And finally, the ultimate goal, empathy. Our sources even provide a helpful 5-part structure for delivering empathy effectively.
Yes, and empathy isn't just feeling bad for the patient. It's a structured communication tool. You name the emotion. You sound frustrated. Understand the situation. I understand this news is upsetting. Respect their reaction. That's a completely reasonable way to feel. Support the patient, and then explore the depth of that emotion, inviting them to share more.
Empathy is a key part of building trust, but building rapport, that conversational bridge, can be hard, especially when time is limited. Our material provides concrete steps to do this through the PEARLS model.
The PEARLS model is an excellent, really practical framework for building rapport. Let's break down all 6 components using the specific examples from the sources because they show exactly how to turn theory into actual dialogue.
Okay, starting with P for partnership.
Partnership means you're explicitly positioning yourself as working with the patient to find solutions. The example is perfect. We have difficult times ahead, but we will work together to provide you the best possible care consistent with your goals, values, and beliefs.
It signals collaboration.
Right, and shared decision-making. It reduces that hierarchical power dynamic.
B is for empathy. We know this is about displaying understanding. In the PEARLS context, the example focuses on linking the emotion to the context.
You appear sad. I understand that the news about your illness may have upset you, especially since you mentioned your family is so far away right now. It's specific, and it validates the feeling.
A is for apology. This is challenging for a lot of professionals, but it's so necessary when the system or the clinician fails.
Apology means taking personal responsibility when it's appropriate. The example given is about a time failure. I am very sorry that I had to attend to an emergency and you had to wait for me for 40 minutes. However, I still would like to understand your concerns so that I can help you if you choose to allow me.
That validates their time and gives them back control.
It does.
R is for respect.
Respect means positively encouraging patients, especially when they're trying to make major behavior changes. It acknowledges the struggle while praising the effort. The example from the source is powerful. I understand that you have had a tough time trying to stop drinking alcohol. I also know that you have given your best effort every time, and I appreciate the effort you put in.
That's incredibly supportive.
It is.
L is for legitimation.
Legitimation involves normalizing the patient's feelings, letting them know that their emotional response is understandable or rational. The source example. It is understandable to feel anxious about the uncertainty as we move forward.
It takes the burden of feeling wrong off the patient.
Exactly.
And finally, S is for support.
Support means reassuring the patient of your continued availability and commitment. It's a promise. The example. I am here to support you through the process, even if we hit bumps in the road, and I will answer any questions you may have along the way.
Building rapport with PEARLS is essential, but that trust has to be preserved when you're delivering difficult, life-altering news.
For sure.
The SPIKES model provides a non-negotiable, structured framework to maintain control and empathy during these challenging conversations.
And delivering bad news without this kind of structure often leads to the patient recalling very little of what was said. They get overwhelmed or they feel abandoned. SPIKES ensures you proceed thoughtfully.
Step 1. S for setting.
The setting is everything. You have to ensure a private environment, physically minimize distractions, put your phone away, close the computer screen, and critically, you sit down at eye level with the patient.
You never deliver bad news standing over someone.
Never. It signals respect, focus, and that you are present for the entire emotional weight of the discussion.
Step 2. P for perception.
This is maybe the most overlooked step. Always ask what the patient already knows or thinks about their health before you deliver any new information. It helps you bridge the gap between their understanding and the reality you're about to present.
Step 3. I for invitation.
You have to respect the patient's autonomy. Ask them directly if they want to hear the news now and how much detail they prefer. Some patients want every statistic. Others need a big picture overview first.
It maintains their control when they feel like it's slipping away.
Right.
Step 4. K for knowledge.
You educate the patient in small, manageable, digestible chunks. The warning shot approach. You avoid excessive medical jargon, and you have to pause frequently to assess their understanding step by step.
To make sure they're not getting overwhelmed.
Right, or mentally shutting down.
Step 5. E for emotions.
After you deliver the core knowledge, you have to anticipate and respond to their emotional reaction. If they respond with shock, denial, tears, or anger, you have to acknowledge and empathize with that.
You listen, validate, and provide silence.
Exactly. You don't immediately jump into solutions.
And only once that emotional response is acknowledged do we move to step 6. S for strategy and summary.
Precisely. Strategy is the roadmap for the future. Once emotions are addressed, you outline the next steps, discuss clear goals of care, and schedule follow-up appointments. The patient has to leave feeling like there is a path forward.
The ability to communicate effectively requires cultural and personal humility. A core part of HSS is ensuring the system serves all patients equally, which means tailoring the history-taking process.
Definitely.
Let's start with gender and sexuality inclusive history-taking. What are the specific required behaviors for clinicians here?
Well, the primary rule is to avoid making assumptions about a patient's sexual orientation, gender identity, or sexual behavior without asking them directly. And if the information isn't relevant to why they're there, say a broken arm, you just don't ask.
And what about specific language use?
Clinicians have to note that the patient may identify as a different gender than the sex assigned at birth, and they must use the patient's preferred pronouns and names. Use gender-neutral terms like partner or spouse rather than assuming a husband or wife.
And crucial,
Critically, you have to assure the patient that whatever they share is strictly confidential and won't be disclosed to anyone without their explicit permission. That's how you build trust and encourage honesty.
beyond individual identity, we have to address culturally inclusive history-taking. This goes far beyond just surface-level respect, right? It's about integrating their worldview into the treatment plan.
Right. Clinicians must systematically consider the patient's culture, their specific life goals, their values, and their beliefs when designing a treatment plan, especially for life-altering decisions. You have to actively try to think about the illness and the treatment from their perspective.
There's one crucial, high-stakes example cited in our sources that makes this distinction crystal clear, where cultural refusal of care meets professional ethical obligation, especially with minors.
This is where autonomy clashes violently with beneficence. The example highlights that a competent Jehovah's Witness adult can refuse a life-saving blood transfusion for themselves.
And legally, the clinician has to respect that.
They must respect that refusal based on the principle of autonomy. However, if they refuse that same treatment for their child, a child who is below the legal age and is facing a life-threatening situation, this changes everything.
Why does it change? Because the child's a protected minor.
Exactly. The key fact is that the child is not legally competent to make that decision. When a treatment is life-saving, the parent's consent is superseded. Their autonomy doesn't extend to sacrificing the child's life.
So the clinician's obligation to the child's best interest beneficence takes over.
It has to. The clinician must involve legal authority, like seeking an immediate court order, to ensure that child receives the life-saving measure. The ethical burden on the clinician in that moment is just immense.
Let's look at two final areas of communication mastery: motivational interviewing for deep behavior change and adapting communication for special populations.
Motivational interviewing is a dedicated technique focused on changing behavior, quitting smoking, improving diet, sticking to a medication schedule. The clinician's role is to counsel the patient, not by confrontation, but by guiding them to find their own internal reasons for change.
And if a patient expresses a desire to change, how should the clinician structure the goals?
The goals have to be SMART: specific, measurable, achievable, relevant, and time-bound. Setting a SMART goal provides concrete steps instead of just vague hopes.
What are the key rules for communicating with patients who have disabilities?
The first rule is one of respect. Always speak first to the patient and ask them how they identify themselves. Don't assume. You should get additional information from caregivers only when appropriate and with the patient's consent.
And what about specific accommodations?
For patients with speech difficulties, you have to provide extra time and be patient. For cognitive impairment, use simple language, direct yes/no questions. If they're hard of hearing, ask about their preferred mode of communication.
And crucially, you don't skip the physical exam.
You do not omit the physical examination, even if the disability makes it challenging. Comprehensive care is still required.
A quick final note on interpreters. We have to avoid the simple solutions here.
Absolutely. When patients don't speak English or have trouble communicating, clinicians must use a professionally trained medical interpreter for all critical communication. Never use family members, friends, or simple translator apps.
Because that can lead to major errors.
Major errors, inaccuracies, or a breach of professional boundaries is just not the standard of care.
So once the interview is done and goals are set, clinicians have to tailor their education based on where the patient actually is in their readiness to change. Our sources provide a 5-stage model for this.
Yes, this model, detailed in Table 2.52, is a roadmap for assessing patient motivation. Clinicians use different strategies depending on the stage.
Let's review them, starting with Stage 1, pre-contemplation.
The patient is either in denial or just ignorant of the problem. They haven't even remotely thought about stopping the substance use, to use the example. The clinician's role here is just to raise awareness gently.
Stage 2, contemplation.
This is the stage of ambivalence. They're weighing the pros and cons. The patient recognizes the problem and considers treatment, but they haven't committed to anything yet.
Stage 3, preparation.
The patient is actively planning and experimenting with small changes, gathering information. The example is the patient going to a doctor to ask about quitting, maybe researching local rehab programs. They're getting ready for the jump.
Stage 4, action.
This is the crucial stage where the patient is taking direct action, spending significant time and energy on the new behavior. The example: the patient enters a rehabilitation facility. Active change is happening.
And stage 5, maintenance.
This stage is all about maintaining the new behavior, embedding it into their life, and avoiding relapse. The example is the patient continuing recovery meetings. The clinician's role here is supporting relapse prevention.
We shift now from individual interaction to system dynamics. The focus in modern HSS has to shift from blaming individuals for past errors to actively preventing future errors by designing safer systems. This starts with the organizational environment.
Yes, the safety culture. It's a foundational concept. It's defined as an organization's collective beliefs, perceptions, and values about errors and the employee's relationship to risk.
So in a strong safety culture, employees feel safe reporting errors.
Exactly. They can report errors or near misses without fear of being punished, knowing the system, not the person, will be investigated.
How do organizations use this culture to drive tangible improvements? They rely on continuous cycles, like the PDSA cycle.
The PDSA cycle is a continuous four-step method. Plan, identify a problem and propose a change. Do, implement the change on a small scale. Study, measure the effects and see if it worked. Act, standardize the successful change or abandon it and replan.
It ensures improvements are tested and embedded, not just mandated. When a system fails, we need to understand why. The famous Swiss cheese model is the classic risk assessment model for this.
This model, from James Reason, posits that catastrophic system failures errors that harm the patient happen when multiple safeguards, the slices of cheese, fail at the same time.
So the holes in all the slices line up.
The holes line up perfectly, allowing harm to pass through the system. The goal of safety science is to identify those holes, which represent system weaknesses, and install more safeguards to prevent that alignment in the future.
If we're improving systems with cycles like PDSA, we have to measure the impact. So how is healthcare quality actually measured? Our sources define 4 crucial dimensions.
The first dimension is structural. This is the easiest to measure. It assesses the physical equipment, resources, and facilities. The quality is measured by the inputs.
Example would be
Counting the number of MRI machines or just checking the functionality of the machine used to evaluate potassium levels in a lab.
the second is process.
Process assesses the actual function and adherence to best practices. Quality here is measured by doing the right thing. An example would be tracking the percentage of eligible patients who got a flu shot.
The third is outcome.
Outcome is the measurement of the direct, measurable impact on the patient. This is the gold standard. For example, tracking the average potassium levels of dialysis patients over time, or the rate of post-surgical infection.
This is the ultimate goal, improving health.
It is.
And the fourth dimension, which is essential for a systemic view, is balancing.
Balancing assesses the impact of an intervention on other systems or outcomes. You have to check for unintended consequences.
So if you fix one thing, you don't want to break something else.
Precisely. If you implement a protocol to drop potassium levels, but it leads to a spike in ER visits for dehydration, that's a balancing failure. You have to make sure improving one metric doesn't degrade another.
Now we get into defining the adverse events themselves, the errors. Our sources break down 7 distinct types.
And these distinctions are critical for root cause analysis because they tell you where to focus the investigation on the individual or on the system design.
We start with active error.
An active error happens at the frontline operator level, the person directly interacting with the patient. The impact is immediate.
Like a nurse giving the wrong dose.
Exactly. Or a surgeon operating on the wrong site, or a clinician writing an illegible order that leads to a mistake.
Next, latent error.
Latent errors are the indirect processes or system flaws that create accidents waiting to happen. They're usually related to poor design or bad policies.
So, an example.
The example provided is having different types of IV pumps used in the same hospital, which can lead to confusion, misuse, and an environment that's just ripe for an active error to occur.
Events are self-explanatory, but they have to be defined stringently.
Right. Never. Events are egregious errors that should never, under any circumstances, happen. They're preventable and usually have devastating consequences.
Wrong site surgery.
That's the classic example. Wrong foot amputation, or leaving a foreign object inside a patient during surgery.
What distinguishes a near miss?
A near miss is an adverse event that could have led to harm but didn't, because something, an intervention, detection, or just luck, prevented the error from reaching the patient.
Like a pharmacist catching a medication error.
Exactly. They catch it just before it's administered and correct it.
Then we have the general medical error.
A medical error is defined as a failure to complete a planned action as intended, or using the wrong plan to achieve an aim, administering the wrong dose, or writing an order with a misplaced decimal point. A failure of execution or planning.
Negligence sounds like the legal elevation of an error.
It is. Negligence occurs when there's a clear failure to meet the expected standard of care, and that failure leads directly to patient harm. For instance, failing to follow up on a critical abnormal test result, which leads to a delay in a cancer diagnosis.
Finally, the sentinel event.
This is any unexpected occurrence that involves death or serious physical or psychological harm, or the risk of it. It requires immediate, serious investigation and response by the organization.
An example would be?
A patient suffering an unexpected serious adverse outcome during transport between two different procedures within the hospital.
The system is designed by humans, and errors are often traced back to human factors, specifically healthcare worker burnout and fatigue. What causes this, and how does it connect to latent error?
Burnout is caused by a mix of intrinsic demands, the job itself, individual susceptibility, and critically poor work organization. Sleep deprivation, emotional stress, long hours. All of these are highly correlated with impaired cognitive function.
Which increases the chance of an active error.
Exactly. Especially when the system defenses, the cheese slices, are already weak, burnout feeds the latent errors.
So our sources list several system-level interventions for minimizing burnout.
The focus has to be on structural support. Setting clear, achievable goals, providing training for coping strategies, encouraging support groups, organizing workloads, providing flexible schedules, and ensuring adequate facilities. It's a commitment to the well-being of the entire workforce.
Let's compare the two main models for analyzing medical errors: root cause analysis, RCA, and failure mode and effects analysis, FMEA.
They serve opposing but necessary functions. Root cause analysis, RCA, is typically done retrospectively after a sentinel event has already happened to decrease the odds of it happening again.
So it's an inductive process, looking for the underlying cause.
Right. Using tools like the 5 whys or fishbone diagrams to find the real system cause of the error.
And failure mode and effects analysis, FMEA, looks forward.
FMEA is applied prospectively before an error happens. It's preventative engineering. It uses deductive reasoning to determine the probability and impact of potential system failures, so you can install safeguards and eliminate latent errors before anyone gets hurt.
So RCA looks back to learn from the past. FMEA looks forward to predict and prevent the future.
A perfect summary.
We've mapped the system's operational and safety mechanics. Now we move into the ethical and legal scaffolding that governs every single clinical action. Understanding the core principles of bioethics is non-negotiable for anyone navigating the healthcare system.
These are the 4 foundational pillars that define the clinician's obligations.
Let's start with respect for autonomy. Our sources say this principle is absolute. What does that absolute nature actually mean in practice?
It means that clinicians are obligated to respect the patient's preferences and choices about their own body and care, as long as the patient has the capacity to make that decision. The patient has the right to refuse treatments, even life-saving ones.
You call autonomy absolute, but we've seen examples where it's overridden by public safety, like with TB, or by beneficence for a child. How can a principle be absolute if the exceptions are so life and death?
That's where the nuance of HSS lies. Autonomy is absolute unless it violates the law or directly endangers the health and welfare of others.
And the high-stakes example cited is the pregnant woman.
Exactly. A pregnant woman has the right to refuse a cesarean section despite potential, even extreme risk to the fetus. In the U.S., the clinician is legally and ethically obligated to respect the mother's capacity and choice, even if it jeopardizes the fetus. Her capacity is respected, even at great cost.
The second pillar is beneficence.
Beneficence means clinicians have a responsibility to act in the patient's best interest. The relationship between beneficence and autonomy is the source of endless ethical dilemmas. If the patient is competent, autonomy wins. If incompetent, beneficence wins.
Let's go back to the difficult Jehovah's Witness child example through the lens of beneficence.
The clinician's duty of beneficence compels them to recommend and secure a life-saving blood transfusion for a minor child, even if the parent refuses. The clinician's obligation to the child's best interest must outweigh the parent's autonomy in making a decision that would lead to the child's death.
Pillar 3, non-maleficence.
This is the ancient Hippocratic principle, do no harm. All medical interventions have risks, so clinicians should only recommend treatments where the benefits are likely to outweigh the known risks. It also includes the duty to clearly explain the risks of refusing treatment.
And the final pillar, justice.
Justice refers to fairness and equality in how healthcare resources and services are distributed. This is a massive ongoing challenge for health policy, particularly in ensuring vulnerable populations get equitable care. The source provides the example of a state designing a program for homeless people, an attempt to allocate limited resources fairly.
The doctor-patient relationship itself is fundamentally a voluntary relationship.
It is. It requires mutual agreement and trust from both sides.
But there are rules and exceptions. You mentioned emergency management.
Yes. In a hospital, emergency care is provided regardless of whether a formal, long-term relationship has been established. But for non-emergent care, the patient has the right to refuse care and find another clinician. And the clinician is not obligated to accept every person for non-emergent care.
Let's address the highly sensitive issue of doctor-patient sexual relationships. Why is this boundary absolute?
Sexual contact between clinicians and patients is always inappropriate and always exploitative. It doesn't matter who initiates it. There's an inherent power imbalance. The rule is stringent. The professional relationship must be terminated before any sexual relationship begins.
Competence and decision-making capacity. These two terms are constantly used interchangeably, but in HSS and law, they are very different. Competence is the legal status.
Right. Competence is a person's global and legal ability to make decisions. It is judged exclusively by the courts. A person is legally presumed competent until a judge says otherwise.
Decision-making capacity, however, is clinical.
Capacity is the clinical assessment of a patient's ability to handle a specific medical decision. This is assessed by a clinician. To have capacity, the patient has to be able to understand the information, appreciate the consequences, communicate a clear choice, and deliberate rationally based on their values.
What are the nuances of testing for capacity? Does every patient who refuses treatment need a psych eval?
Not at all. Capacity is best understood as varying with the complexity and risk of the decision. The capacity you need to agree to stitches for a small cut is vastly different from the capacity needed for a liver transplant.
So it's decision-specific, not global. When can a patient's refusal of treatment be legally or ethically overruled?
As we touched on, a patient's refusal can be overruled if their choice endangers the health and welfare of others. The clearest example is a patient with active infectious tuberculosis who refuses medication. They must undergo treatment to protect public health.
And we have to strongly emphasize the key fact about mental illness and capacity because it counters a common stereotype.
Yes. A psychiatric illness, even a severe one like major depression, does not automatically mean decision-making capacity is lost. You cannot deny a patient's autonomy just based on their diagnosis. Capacity has to be evaluated clinically for each decision.
Informed consent is the procedural manifestation of autonomy. It's the cornerstone of ethical practice.
And it has rigid requirements.
What are the 3 non-negotiable conditions for consent to be valid?
First, it must be willing and voluntary, no coercion. Second, it must follow full disclosure of all risks, benefits, and alternatives. And third, it must be obtained after the patient is adequately informed, meaning they truly understand what's being presented.
What about the discussion itself? Language and documentation.
The discussion has to be in language the patient can clearly understand. Professional translation is necessary if there's a language barrier. And informed consent must always be documented in the medical record.
And patients can change their mind at any time.
At any time, even minutes before a procedure, and that has to be honored.
Are there any situations where informed consent is not required?
Yes, in emergencies. The example is a trauma patient who arrives unresponsive with cerebral edema. You provide the life-saving resuscitation because immediate action is necessary to prevent death. Consent is implied.
What about unconscious patients with no family around?
In that case, if action isn't immediately required but consent is needed, a witness telephone consent from the legally appropriate surrogate is considered valid if it's the only way to get consent in a timely manner.
How do we handle informed consent for incapacitated individuals who may have expressed prior wishes?
You have to respect the patient's last known wishes, whether they were oral or written. If a patient repeatedly and clearly refused a procedure while they were competent, that procedure should not be performed once they lose consciousness.
Let's look at the complexities of informed consent in reproductive health. Who holds the legal power?
The mother's autonomy is paramount and supersedes the rights of the fetus. Fathers or partners have no legal right to consent on pregnancy-related procedures. The decision rests entirely with the patient.
Now, informed consent for minors. What's the standard rule?
The general rule is simple. Minors, usually under 18, cannot legally consent. Parent or guardian consent is required.
What about the exceptions? We mentioned emergencies. What about legal status?
Legal emancipation. Emancipated minors, those who are married in the armed forces or are financially independent parents, provide their own medical consent. They're considered legally independent adults.
And treatments minors can consent to nationally.
Yes, this is crucial for public health. Across the U.S., minors can consent to treatment for sexually transmitted infections, STIs, and for issues related to substance abuse, often without parental notification, to encourage them to seek care without fear.
And what if a minor refuses treatment, even if the parent consents?
The clinician should strongly encourage discussion between the parent and the minor. There's no consistent national standard on when to notify parents against a minor's wishes, which creates a huge ethical challenge for the clinician, who is left to decide what's in the minor's best interest.
Let's solidify the difficult legal boundary regarding parental refusal of treatment for children.
A parent has the right to refuse non-life-sustaining treatment for a child as long as the decision doesn't pose a serious threat to the child's well-being.
But if the decision actively endangers the child's life?
If the parental decision is not in the child's best interest, especially when the child faces serious threat or death, the clinician has a professional obligation to refuse the refusal and seek an immediate court order.
So in that emergent, life-threatening situation with the blood transfusion?
The clinician should not waste time debating. They must immediately get a court order or legal warrant to secure the life-saving measure, overriding the parent's harmful decision.
Moving into the most emotionally and legally fraught area of HSS end-of-life decisions where clarity is paramount.
Absolutely.
Advanced directives and end-of-life decision-making. Let's start with advanced directives, or ADs.
Advanced directives are written instructions completed by a competent adult about their wishes for medical treatment if they lose capacity. They outline wishes to maintain, withhold, or withdraw life-sustaining treatment. And crucially, a formal AD overrides the family's wishes.
Distinguish that from the POLA.
The POLIST physician orders for life-sustaining treatment is a specific physician's order outlining the patient's care preferences at the end of life, like their DNR status or feeding tube decisions. It's based on a recent medical evaluation and is not a replacement for the AD. It's a portable, actionable medical order.
When a patient is unconscious, the decisions fall to the surrogate decision-maker, who has ultimate authority.
If the patient is incapacitated, a surrogate makes decisions. The highest legal weight goes to the durable power of attorney or healthcare proxy, which is a formal document legally designating a specific surrogate.
Because that person was chosen directly by the patient, why they were competent?
Exactly.
What if there is no formal proxy? We rely on a strict hierarchy, often remembered by the mnemonic ship is Bobis, for the patient.
That legally mandated hierarchy is generally followed. Children, husband, wife, spouse, incapacitated adults' parents, parents of the patient, siblings, and finally a trusted friend. And their decisions must still try to align with the patient's known wishes.
What happens if family members in that hierarchy disagree?
If there's disagreement among family of the same rank, like 2 children, the clinician should first encourage discussion and mediation. If no consensus is reached, they have a duty to refer the case to the hospital ethics committee or, failing that, seek a court order.
Let's clarify DNR-DNI orders. They are so often misinterpreted as a blanket refusal of all medical care.
DNR and DNI orders are very precise. They are based on patient preferences regarding cardiac pulmonary resuscitation and intubation only. Crucially, these orders do not prevent other therapeutic treatments like antibiotics, dialysis, chemotherapy, or blood transfusions.
Finally, the ethics of withdrawal of life-sustaining treatment. Is it ethically different to stop a treatment than to never start it?
Patients have the absolute right to forego or withdraw life-sustaining treatment. And the powerful ethical principle here is the principle of equivalence. There is no ethical distinction between withholding treatment initially and withdrawing treatment that's already started. Both are equally acceptable if they align with the patient's wishes.
We have to tackle the most sensitive topics at the end of life: euthanasia and clinician-assisted suicide.
Euthanasia, which is the administration of a lethal agent by the healthcare provider to end the patient's life, is firmly opposed by the AMA Code of Medical Ethics and is illegal in all states in the U.S.
How does that differ from clinician-assisted suicide, or CAS?
With CAS, the clinician prescribes a lethal agent for the patient to self-administer. This remains highly debated, but it is legal in a select, growing number of states, like Oregon, Washington, Vermont, Colorado, and California.
Where does hospice care fit into this spectrum?
Hospice care is a highly specialized subset of palliative care. It's focused entirely on comfort, pain management, and quality of life when the patient's prognosis is confirmed to be 6 months or less. The goal is comfort, not cure.
Within hospice, there's an important ethical concept regarding pain relief, especially with high doses: the principle of double effect.
This principle addresses the moral complexity of pain relief. It states that if a medication is given to relieve suffering, but it secondarily and unintentionally hastens the patient's death, this is ethically acceptable. The intent must be purely palliative, to relieve suffering, not to cause death. The distinction is all about intent.
And what about futile treatment? When can a clinician ethically refuse to provide treatment?
Clinicians are not ethically obligated to provide treatment if it's deemed medically futile. This happens if there's no physiological rationale, the intervention has already failed, maximal intervention is currently failing, or the treatment won't achieve the established goals of care.
The principle of full disclosure is non-negotiable. Patients have a right to know their full medical status.
And they have full HIPAA rights to copies of their medical records.
What if the patient's family asks the clinician to withhold a frightening diagnosis from the patient?
Because of the patient's absolute right to autonomy, a clinician cannot be required to withhold information from the patient. If a family asks you not to share a diagnosis, the patient must still be told the truth. The patient controls their own knowledge.
Are there any rare exceptions to this rule?
Yes, in rare and highly controversial cases, information can be withheld under extremely strict conditions. If immediate harm is likely, for example, or if disclosure would genuinely cause more harm than good, which is a decision that should be made with the hospital ethics committee. But therapeutic privilege does not apply to withholding information about errors or negligence.
Let's quickly revisit the setting for delivering news, now in the context of disclosure.
The Spikes model is perfect here. The setting must be private and focused. Perception, find out what they know. Invitation, ask how much detail they want. Knowledge, deliver in small pieces. Emotions, acknowledge their reaction. And strategy and summary, make sure they leave with a clear plan.
We turn now to professional accountability. Malpractice. How is medical malpractice legally defined? It requires 4 specific elements.
Right. Malpractice occurs when an injury results from a professional failure to meet the standard of care. This is remembered by the 4 Ds of malpractice.
Okay, where are they?
Duty. The clinician owed a duty to the patient. Dereliction. There was a breach of that duty. Damage. Harm occurred to the patient. And direct cause. The breach of duty directly caused the harm. All 4 must be proven in court.
Are healthcare providers protected in any way when they provide basic assistance outside of their professional setting, like at an accident?
Yes, this is covered by Good Samaritan laws. These laws protect certified healthcare providers who render basic first aid outside a clinical setting, encouraging them to help victims without fear of liability as long as they act in good faith.
Finally, the serious issue of the impaired practicing clinician. What is the definition and what is the obligation of their colleagues?
An impaired clinician is one whose professional inability due to illness, substance abuse, severe burnout affects their job and compromises patient safety. And a clinician has an absolute overriding obligation to protect patients by reporting colleagues who may be impaired.
To whom?
To the peer review body, the state medical board, or a higher authority in the institution.
Give us the critical example from the sources that highlights the need for immediate reporting.
If a patient reports that a surgeon smells of alcohol right before a procedure, the clinician who gets that report must immediately document it, stop the procedure to ensure the patient's safety, and report the situation directly to the state licensing board or a high authority immediately. You cannot wait. If the threat is immediate, the reporting is immediate.
We conclude our deep dive by covering the rules governing information and integrity. Confidentiality, governed by HIPAA, is the national standard for protecting health information.
And the core principle is that protected health information should only be discussed with those directly involved in the patient's care. It's strictly confidential except in specific, legally mandated scenarios.
That's the key conflict. When is confidentiality overridden? When does the duty to warn or duty to protect apply?
Confidentiality is overridden in several critical situations where public safety is a concern.
Such as,
The duty to protect warn. If there's a credible threat of serious harm to an identifiable victim, you have to warn the victim and notify the police. Public health concerns. Mandatory reporting of infectious diseases like HIV, active TB, or COVID-19.
what else?
Child or elder abuse, neglect. Mandatory reporting in all states. Reporting injuries related to violence or crime like gunshot wounds. And traffic safety. If a patient's medical condition makes them a danger on the road, like having poorly controlled seizures.
When patients volunteer for clinical trials, a different set of ethical guidelines kicks in. This is rooted in the Declaration of Helsinki.
Right. The Declaration of Helsinki is the international standard that binds researchers to ensuring patient safety and the integrity of research results. It states that the health and well-being of the patient participant must always be the primary consideration.
And what are the key ethical requirements for research consent?
Informed consent for research has to be incredibly detailed. It must clearly state the purpose, all known risks, expected benefits, and alternative, including not participating. And participants should always benefit from the trial or from other equivalent treatment.
How do ethical concerns change for control populations in research?
For pregnant patients, the rule is strict. No unnecessary risk to mother or child. For children, you have to get assent or agreement from the child and formal consent from the guardian. And for incarcerated patients, you must protect them from undue influence or coercion to participate.
The final area we have to cover ensures financial and ethical integrity. Conflict of interest, COI.
A COI occurs when a clinician finds that a personal interest, usually a financial one, conflicts with their professional obligations to the patient.
The classic example is owning stock in a drug company whose product you prescribe.
Exactly. The clinician must disclose existing COIs in financial meetings and to patients when it's relevant. The integrity of the decision-making process has to be paramount.
What about gifts from patients? When are they acceptable?
Gifts from patients can be accepted as appreciation if they are small and non-monetary, and they don't impair the patient-doctor relationship by creating a sense of obligation. You have to respectfully decline large financial or expensive emotional gifts.
And finally, gifts from drug companies, an area governed by stringent federal regulations.
Gifts over $100 annually are subject to disclosure requirements, often mandated by the Sunshine Act. Small gifts under $100 a year, like meals during a talk or educational charts, are often exempt, but even these small items should never, under any circumstances, influence a clinician's prescribing habits. The patient's best interest must always, always prevail.
We have completed an exhaustive, systematic map of the operational, ethical, and legal terrain of healthcare. We started with the flow of money and insurance plans, navigated the critical frameworks for human interaction, pearls for rapport and spikes for crisis, and analyzed the stringent rules governing end-of-life decisions and professional accountability. This entire structure is the scaffolding that supports medicine today.
And the common thread running through all these high-yield facts is the unwavering commitment to the patient's autonomy, safety, and best interest, all governed by these rigorous ethical and legal frameworks. Understanding these systems, the nuances of capitation versus fee-for-service, the four dimensions of quality, the crucial distinction between competence and capacity, it makes you a far more informed participant in your own healthcare journey.
Whether you're receiving care or administering it.
Exactly.
What stands out to you, for me, it's the realization that the complexity of modern healthcare demands systemic engineering solutions like the PDSA cycle and the Swiss cheese model, just as urgently as it demands profound, trained human interpersonal skills like what you find in the Pearls model. It's not enough to be clinically brilliant.
No, it's not.
One must also be a brilliant system navigator, because even the best clinician can fail if the system itself is structurally flawed.
And if the core principle of autonomy is absolute, as our sources state, this raises a fascinating question for the future. How should health systems ethically handle the growing influence of highly accurate AI decision support systems? Specifically, what happens when that AI's superior predictive recommendation conflicts directly with a patient's capacity-based refusal of treatment? That is something truly worth mulling over as technology advances.
A perfect final thought to close out this deep dive into health systems science. Thank you for joining us.
Until next time.